So yeah, sorry. So based on the reflection of the Doppler waves, signals are converted into velocities. So basically, we are equating the velocities as flows because we consider because most of the times we are imaging just the conduit vessels, or let's say proximal vessels, which we presume that the diameter or the size of the vessel don't vary much, and hence we are equating the velocities to flows. That is one of the inherent drawbacks of transcranial Dopplers. So this statement of Doppler measures velocity but not the speed. So velocity also comprises of the direction. So speed doesn't have a direction, so it's not a vector. So velocity, but whereas velocity is a vector. So again, how does the machine with this integrated algorithm convert the reflected velocities or the reflected speeds or the reflected waves into the velocities? This is what is called as the Doppler shift frequency equation. The main thing which we need to remember is the trigonometric mathematical sign of cos theta. So the angle of compensation can be achieved, or it can be reasonably good up till angle of 60 degrees. So because cos 90 is 0, so at 90 degrees if we insolate, we are not going to get anything. So up till an angle of 60 degrees, we are reasonably okay in obtaining reasonable accuracy in our measurement. So quickly jumping into the transcranial Doppler types. So they are divided into imaging and non-imaging Dopplers. So on the left half of the screen is the imaging Doppler, where we do see the B mode of the brain, and we identify certain landmarks, and then we try to insonate the vessels based on the color or based on the pulsations, and then we get a spectral waveform like this, and that's how the values are interpreted. Whereas in the non-imaging Doppler, it's not an image. So as the name itself indicates, it's not an imaging Doppler, it's a non-imaging Doppler, where we identify the vessel based on the depth of insonation, and it is more feasible for continuous monitoring, and it's just a difference in the mode, and it may not be very helpful in B mode ultrasonography, but it serves all other purposes well enough. So the type of Doppler which we use, there are two types, which is pulse wave and the continuous wave. So the pulse wave Doppler emits no the pulse, it emits the Dopplers in the pulses, whereas continuous wave does it in continuous fashion. This is what we call as the pulse repetition frequency, which is concerned with the aliasing. That is that's technical details of how an image which is acquired, or how the spectral waveform which is acquired is in the is in the normal sort of limits based on the Nyquist limit and the pulse repetition frequency. So the relationship between the imaging and non-imaging has been beautifully described here. So this is how imaging Doppler can be equated to a non-imaging Doppler. So if we just remove the inset of the image here, and we just depend on, rely on the depth of insonation, that's how we get this non-imaging Doppler. So both of them serve the purpose of identifying the vessels and identifying the spectral waveforms. So TCD examination. So position of the patient is always in supine, and head end has to be elevated as some guidelines will recommend by at least 30 degrees, and it has to remain the same on serial examinations. So the phased array probe is used. If at all TCD preset is selected, the pointer is directed anteriorly, and if at all if it's unavailable, an echo preset can also be used with the pointer in the posterior direction. The Nyquist limit, as I was telling, we need to select the lowest Nyquist limit on the on our ultrasound machine. So the Nyquist limit is nothing but pulse repetition frequency by 2. So if the velocity of the blood vessel is higher than the Nyquist limit, it leads to a phenomenon of aliasing. We have a few slides, in the case discussion where we demonstrate what is aliasing and how do we adjust the Nyquist limit to reduce the aliasing. So the transtemporal window, there are the 5 windows, the 4 commonly used windows. Amongst them, the transtemporal window is most commonly used. So once the vessels are identified with the help of color-coded Doppler sonography, either it can be identified with the help of color, or depending on the pulsation also, the vessels can be insonated in the B mode or the imaging Doppler. Whereas in non-imaging Doppler, it is always and always with the help of the depth of imaging. So how do we take the samplings? It is always 2 to 3 samplings are taken to obtain 2 to 3 samples are taken, and the highest of the values are considered. So what we need to remember is there are only 10 to 20% of the patients who have a poor transtemporal or a poor neurosonographic window. So possibly 80 to 90% of the patients we would still be able to acquire some vessel, or let's say some good window for insonating the major vessels. So we can do all our monitoring or non-invasive ICP estimation in 80 to 90% of our ICU patients. So this is a classical, or let's say a classical spectral tracing of a middle cerebral artery at the depth of probably I'm insonating between 50 to 60 mm. We can see a beautiful spectral waveform. Can one of you unmute and uh, elaborate on things? What all we see here? This is the peak systolic velocity. E, this is the end diastolic velocity. This is the mean flow velocity. And can you see MI and TI on the right upper corner of the screen? So what
Yes,
does
yes.
MI and TI indicate? Can anyone?
MI is in
Yeah,
index.
yeah.
TI, not sure.
Yeah. So MI is mechanical index, as sir was telling, and TI is thermal index. So possibly in all the point of care, or let's say in the bedside sonography in critical care, these two indices are of paramount importance in transcranial Doppler. So here MI is 0.7, TI thermal index is 0.8. So this indicates the safety of the, or let's say the safety measure, or these are the indices which indicates the safety of the ultrasonographic use. Even though the use of POCUS is generally safe, there are two mechanisms by which ultrasound can damage the tissues. That is through the thermal and the non-thermal effects. Thermal effects is as the name itself indicates, it's the heating of the tissues, which is due to the conversion of the ultrasound energy into the heat energy, whereas the non-thermal effects is due to the reflection. So the most of our images, either on B mode or any other modes, are due to the reflection. When there is a reflection of the wave, there is a sort of a negative pressure and a vacuum created. This is the main mechanism of injury in the non-thermal side of it. We need to exercise caution because there are three important things where because why the TCD can be harmful due to thermal or non-thermal effects. Firstly, it is due to the rapid attenuation of the ultrasound by the skull. Hence, we generally tend to use the higher ultrasound intensities, or the ultrasound preset of TCD itself has a higher power, hence which can lead to higher thermal as well as non-thermal damages. Secondly, the bone is a rapid absorber and transmitter of the ultrasound waves, which can itself lead to various other adverse effect compared to the other regions of the body. And third one, when we employ a headset in the non imaging Dopplers, we do tend to keep it for a reasonably long period of time. Let's say if we are monitoring vasospasm in SAH patients, we tend to keep it for more than an hour, or at least if there is no time constraint regarding the shifting of the ultrasound probes, we do tend to keep it on the patient. So this can by itself, continuous monitoring itself can lead to these thermal effects. So the other marker of the intensity of the ultrasound is the power that's indicated here in the non-imaging Dopplers. So power is the intensity of the incident beam. Increasing power means increasing tissue penetration. So the usual ranges of the power is between 350 megawatt to 500 milliwatt, per centimeter square. This is specifically with respect to the transcranial Doppler. It is very important, especially in one window, that is the transorbital window. There have been guidelines which suggest that the power of the insonating probe should be less than 70 milliwatt per centimeter square, because the eye is a very sensitive structure. Even the MI and TI needs to be kept in mind, the mechanical index and the thermal index. This is the foremost takeaway possibly from this introduction class. When we insulate a transorbital window, our power should be less and our mechanical index and thermal index should be less than 1. So this is what I was talking. Two indices, the thermal index and the mechanical index. TI is estimated rise in temperature in degrees centigrade under worst case conditions. And MI is the indicates the probability of mechanical damage by non-thermal processes. That is damage mainly due to the cavitation process. More than one is considered hazardous. MI, as again told, is directly proportional to the peak rarefaction, that is how much of the waves get reflected or transmitted, and inversely proportional to the frequency of the ultrasound beam. So the American ultrasound institute has recommended the transorbital ultrasound to be done at a mechanical index of less than 0.23. So jumping into quickly the windows of insonation: transorbital, transtemporal, submandibular, suboccipital, and frontal we rarely do use, as I told you earlier, transtemporal being the most commonly employed or the commonly used a window for insonation. And this is how the vessels are in relation to the open structure of the skull. As we can see here, there is a this is the MCA, this is the ACA, both, and this is the two MCAs, and this is where we insonate from the lateral aspects using the temporal bone window. This is again the same thing, the various windows of insonation, transtemporal, and the depth and the velocities have been indicated in this figure. And the first and the foremost thing we start before we start insonating, or before we start identifying the or before we start insonating, is to identify the landmarks. So one of you can sort of unmute and identify what could be 1, 2, 3, 4, 5, 6, 7 is in this figure. So this is the transtemporal window, the most commonly employed window for TCD insonation. This is again divided into various things. It's just for the matter of description. Possibly we do tend to slide across all these frontal, anterior, middle, and posterior parts of the transtemporal window. One of you can quickly unmute and, if possible, try to spell out what are we seeing in 1, 2, 3, 4, 5, 6, 7. This is very essential considering the fact that I need to identify landmarks. So if not, we'll just run through. One is anterior fossa, 2 is the sphenoid bone, 3 is the middle cranial fossa, 4 is the posterior fossa, and 5 is the parietal bone. We are insonating through the temporal. 6 is the foramen magnum, and 7 was the clivus. So if we sort of put the half broken skull against the sunlight, we can see this is what we use as an opportunity to insonate. So the most thinnest part of the bone is through the temporal parts, and hence we take this as an opportunity to insonate the vessels. This is again the transtemporal window describing all the vessels. So this is the MCA. This is possibly the ICA. This is giving out the ipsilateral ACA. This is the contralateral ACA, and this is the contralateral MCA. So what we need to identify is the butterfly. Here we can see here, this is the butterfly. So what is the butterfly? Butterfly is the midbrain. So this is what we call as the mesencephalic window. So there are various planes of insonation through the transtemporal window. This is the mesencephalic, or the midbrain view is most commonly employed. That's where we tend to get the butterfly, and that is the landmark through which all the other vessels are identified. So this is again the same. How we insonate transtemporally. We can see here the pointer being anterior, and we can see here again pointer being anterior, and we are insonating through the transtemporal window in our field of insolation comes the ipsilateral MCA, ipsilateral ACA, P1, P2, and if we are lucky enough and if the window is good enough, even we can visualize the contralateral vessels also. The most important landmark being this butterfly. So the butterfly being the midbrain. So this is again to have a better spatial orientation. If patient is standing or sitting, we keep the ultrasound probe with the pointer directed anteriorly, keeping exactly horizontal or slightly the pointer tilted upwards. And this is how we will be able to see the vessels. This is again the same thing. Before we jump into the identification of the vessels, we need to be thorough with the the circle of Willis, structure of circle of Willis. So the ICA gives out the ophthalmic artery, the posterior communicating artery, and then divides off into the ACA and the MCA. So post that, ACA joins the opposite ACA through the ACOM, and also it gives off a branch of and a recurrent artery of Hubner. So the other important branches of the middle cerebral artery is the anterior carotid artery, which can sometimes be insonated on the transtemporal window. Also, the other very interesting vessels which we can sort of identify would be the posterior communicating artery, especially in the context of a fetal PCA, where I have a few images which we will be discussing in the case series section, where the fetal PCAs which are identified with the help of a DSA can be identified with the transcranial Doppler also. The PCA in the context of a fetal PCA, and the other things being the P1 and the P2, and the branches of P1 and P2, especially the posterior choroidal arteries. These are the possible vessels which can be insonated through the transtemporal window. So other vessels, the window of insonation needs to be changed. This is what I was telling. The mesencephalic view. So the transtemporal window. We start off at the mesencephalic view. That is, we identify the butterfly. That is the midbrain. We slightly tilt, and we can see here just anterior to the midbrain. We can see a fluff, which is possibly the suprasellar cisterns or the basal cisterns comprising of CSF. Uh, and this is how the vessels we insonate on the or how we visualize on the transcranial Doppler. This is the ipsilateral M1 followed by M2, which divides. And this is, if we tilt the angle of insonation slightly above, we get the diencephalic view of the transtemporal windows, where we can see here the anterior horns of the lateral ventricles and also the thalamus and the basal ganglia. So third ventricle, lateral ventricles, thalamus, and also the pineal glands are visualized at the diencephalic view of the transtemporal window. If we slide the probe a little bit more above, we can see through the ventricular views, where we can see the lateral ventricles here, the choroid plexus, possibly these, and the corona radiata. So these are so the periventricular structures are the corona radiata. So this is the third plane of a transtemporal window. So three planes being the mesencephalic view, the diencephalic view, and the ventricular views. These views might be very important in identifying patients with hydrocephalus. So this is again the same thing, the mesencephalic view with possibly all the vessels which we could sort of insonate here. And there is, of course, a lot of aliasing here. Here we can see hyperechoic falx cerebri also harboring the ACA, a butterfly shaped midbrain. And we can also see the opposite side vessels, that is the opposite MCA and the opposite P1, P2 also is visualized in this image. This is again the same ipsilateral MCA tracing comprising of P1, P2, and P3. If the vessel of insonation, if the angle of insonation is good enough, we will be able to appreciate all the three waveforms. And P1, as we all know, P1 is greater than P2, greater than P3. Yeah, this was again the same, the ICA insonation with the ICA along with the opposite ACA, and this is again the same, integrating the windows with the vessels. So before we go into the transtemporal and other windows of trans submandibular and other sub occipital windows of insonation. We need to know how is the carotid divided. We all know at the upper margin of the thyroid, the carotid divides into the external ECA and the ICA. There is something called as a Bouthier's classification of ICA, which we all need to know, where the ICA is divided as C1 to C7 segments. The internal carotid doesn't have any extracranial branches, the first branch being the ophthalmic. And this is very important because of the suboccipital view, where we start insonating uh, just beneath the occiput with our angle of insonation directed towards the root of the nose. Uh, and in intubated patients, possibly we can just turn the head towards one side with the help of pillow support, and the insonation can be done through the occipital bones also. What we need to remember is, so between 6 to 8 centimeters of insonation, it is vertebral, and beyond 8 centimeters, the basilar, even though we can see the joining of the basilar always needs to be insonated in the beyond the 8 centimeter cutoff. So this is how the two basilars or the two vertebrals join to form the basilar. So this is one of the things which we had insonated. So this is the suboccipital window through the conventional approach. We can see here the two basilars come in and join to form two vertebrals come in and join to form the basilar. We can also see the picas, the red ones, picas, which are branches of vertebrals being given off on the left image, and the right image indicates again the same vessels, two vertebrals coming and joining to form the basilar with two picas, posterior inferior cerebellar arteries of the bilateral side, being reflected as red insonations, which because the blood flow is towards the probe. And this is again a vertebrobasilar system insonation. We need to know the branches of the vertebral artery. That is V1 to V4. What we are insonating is the intracranial, that is the V4 segment. The vertebral artery is again insonated at 50 to 60 mm, and whereas the basilar artery is always beyond 80 mm. This is again the image indicating how do we insonate through the suboccipital window. So we can see here the angle, the beam starts off here. We insonate the vertebrals, the V4 segment specifically. We tend to get picas also and the basilars. Possibly the other branches or the other uh, lateral branches would indicate the superior and the inferior cerebellar arteries and the anterior inferior cerebellar arteries, which are rare to find. The picas would be the most commonly insonated along with the vertebrals and the basilars. So coming to the, as I told, the most sensitive or the most, important uh, insonation, that is the transorbital, which we need to keep in mind regarding the power and the mechanical index and the thermal index. So anywhere between 4 to 6 mm here indicates the ophthalmic artery, whereas beyond 6 mm, it is beyond 6 centimeters, it is the carotid siphon. So in the transorbital window, we insonate both the ophthalmic artery and the carotid siphon. This insonation is not a part of a routine regular insonation. We don't need to do this as a part of routine like how we do a transtemporal or a suboccipital, where we insonate all the vessels. This assumes significance only to visualize the collateral status of the brain when there is extensive infarct or where there is a ACA or ICA occlusion. To look at the reversal of the flows in the ophthalmic arteries, it becomes a very important component. So transorbital view, the first and the foremost thing which we need to mind is, as I told, we need to keep in mind the mechanical index, thermal index, and the power. We need to follow what is called as LRA, as we all are aware, as low power as reasonably achievable to reduce the side effects. And the depth is set to 10 centimeters, and the structures are divided into intraconal and extraconal. Ophthalmic artery is insonated between 3 to 6 centimeters, and anywhere beyond 6 centimeters, whatever the insonation we get, it is the carotid siphon. How do we differentiate? Possibly not the right way to differentiate. So the ophthalmic artery has a high resistance waveform, whereas the internal carotid, being the internal structure, has a low resistance waveform. This is how the transorbital view is. This is how we do insonate through the transorbital view. As I was telling, this is the major form of collateral. If there is an ICA occlusion here, if there is a complete ICA occlusion below the origin of the ophthalmic artery, so there opens up a collateral from the external carotid, which communicates through the ophthalmic. So here, the normally the ophthalmic artery has a positive deviation, whereas in case of ICA occlusion, there could be a possible reversal. So in such extraordinary cases only, we insonate the transorbital window, especially considering the sensitivity of the damage involved. This is how what I was telling. How do we insonate the beyond 6 centimeters? We can insonate the carotid siphon. So the submandibular view, as we can see, this is one of the vessels which we had insonated in the submandibular. The carotid dividing into the uh, internal and the external carotid. So this view is very important in identifying the velocities for our Lindegard ratios. We never do Lindegard ratios based on linear probes, or let's say, insonation of the common carotids. It's always done through a submandibular view using phased array probe, and this is how we obtain the external carotid waveform, which is an extracranial, which has a high resistance waveform. Or this is the internal carotid, which in the right half of the image shows the internal carotid insonation. And this image is what we take in the Lindegard ratio in cases of subarachnoid hemorrhage. Frontal view, which is very rarely used, the reference point being the third ventricle and the choroid plexus of the third ventricle. And this and A2 here, unlike in the transtemporal, is towards, so it will be red here. We can see in this image, uh, the vessel which we are insonating here is A2, and there appears a tiny sliver of uh, bluish signals, which is probably A3. Frontal window is rarely used, except for, we need to identify anything in the anterior horns of the lateral ventricles. This is again the windows and the vessels which we insonate, and the depth and the flow direction. So this is possibly this we need to sort of mug up, or we need to daily use uh, to have it at our fingertips. So the thumb rule being, any flow velocity is more, or any mean flow velocity is more than 80 is considered abnormal. And quite naturally, the MCAs should always be higher than the ACAs than the PCAs. If there is any reversal, we need to do a detailed examination, or we need to do a detailed insonation of each components of the vessels. In a quick ICU insonation, possibly we can just insonate all the vessels once. If the velocities are matching and are in the decreasing trend, we can possibly skip insulating other vessels. If at all there is some discrepancy, then we need to insulate all the vessels in detail. And this is the depth at which we insulate. What we need to remember is the MCA, which is insulated between 40 to 60 mm. Again, it is divided into various parts, either proximal or distal. And again, transtemporal is between the ACA is between 60 to 70 mm. The A1 is away from the probe, whereas A2 is towards the probe. That is, A1 will always be blue. This is ipsilateral ACA I'm talking of. Coming to the PCA, or the posterior circulation, the P1 segment is always towards, which is insonated with the probe directed posteriorly and insonated at a distance of 60 to 70 mm. And P2 segment is always away, which is blue, which wounds around the butterfly. So when we find the butterfly, so just anterior to the butterfly is the P1 segment, whereas just posterior to the butterfly would be or winding around the butterfly would be the P2 segments. So as we have already mentioned, this basilar artery is insonated between 80 to 120 mm, and vertebral between 60 to 80. And both basilar and vertebral are always away from the probe. and transorbital ophthalmic artery is always towards in normal physiological or normal healthy individuals, which is insonated anywhere between 4 to 6 centimeters. So coming to the tips and tricks before we wind up this. So we need to do window shopping. We need to identify the structure. We need to identify the landmarks, identify which is anterior, which is posterior, which is right and which is left. It is right left agnostic. Only if I mention on the window this is right AC, that's when we will get to know. Whereas if I don't mention, we will never be aware. So hence we need to sort of write it down how do as and when we image the vessels. So the landmarks being base of the skull, sphenoid, petrous in for the transtemporal window. We need to find the butterfly, identify the vessels with the help of the reference points. Color and depth of examination needs to be kept in mind, and the velocities indices also have to be noted, and the variations or the chronological or the descending order needs to be kept in mind before we go ahead with complete examination. So this is again the same, the trans-temporal window. Second. As we can see here, this is the MCA, this is the ACA, this is the P1, this is the P1 coming towards, this is the P2. Here we can see some red signals which are sort of coming out from the P2 segment. Possibly these are all posterior choroidal arteries, which we might tend to get confused with the middle cerebral arteries. So we need to differentiate the vessels coming out. We need to keep the landmarks. The main importance of putting up this slide was to note the difference between the MCAs and the posterior choroidal arteries arising out of the PCAs. So what's this? Anyone can tell? This is again sort of an imitation of a power motion mode or non-imaging Doppler with the help of an imaging Doppler through our machine, where we put across an M mode through the vessels, and at the depth of 6 mm. This is possibly the MCA which I am insonating. We can see a lot of uh, pulsatility. So this patient had a very high pulsatility index. We can just see the reds coming up. He was just on the verge of being brain dead. So we can see there is significant absence of the color flow in for possibly in the diastole. This is just converting imaging or an imaging Doppler into a non-imaging Doppler through putting a AM mode. So this chart is very important. So for each window, there is a reference point. For the transtemporal window, our butterfly is the reference point. For the transforaminal window, the foramen magnum is the reference point. For the transorbital window, the optic nerve and the eyeball or the conal structures are the reference point. For the submandibular window, the carotid artery shadow is the reference point. Whereas for the frontal window, which is rarely used, the third ventricle and the frontal halls of the lateral ventricles would be the window. If you're lost in any of these windows, we need to always come back to the reference point. Quickly about the venous system insonation. So there are two.
Vinay sir.
Yeah.
Yeah, I think the session will close automatically soon. It is showing less than 1 minute. There
Yeah.
is another link as posted in the group.
Yeah.
We can use it.
Okay. Okay. 1 second. Thank you. Thank you, Mohan.